Okay, hour number 3. So far, so good. All right, now we're up to the most difficult topic that I think. It's the hemolytic anemias. There's a lot of them, but a lot of them are very similar. They're very similar. When you get hemolysis, you're going to get acute onset. You're going to get breakdown of red cells, so you're going to get jaundice from unconjugated indirect bilirubin. Now that can't be in the urine. It can only be in the blood. So it's going to make you jaundice. LDH is going to be up for all these. When you have hemolysis, LDH is up because cells are being lysed. Now if it's intravascular primarily, you're going to have it haptoglobin go down. You're going to get hemoglobin in the urine and potentially renal failure. And eventually you'll get some hemosider in the urine too. If it's extravascular in the liver and spleen, well, they often get enlarged, but you don't usually get the haptoglobin and you don't get the hemosiderin. Make sense? All right, now let's talk about sickle cell. This is probably the most important of all the hemolytic anemias because you're going to see it and it's a very severe disease. So this is a hereditary form of chronic hemolysis. It ranges from asymptomatic cases like in the traits to severe overwhelming crises that can literally kill a patient. Now it's characterized by red cells that sickle. They become sickle. And they smear. Do you see it right smack in the middle? Do you see it yet? I'll point to it, but do you see it on your own? Do you see the sickle cell? There you go. Right smack in the middle. Nice sickle cell. Here's another one over here. Here's another one over here. One over here. Man, they're all over the place. Here's one over here. Here's one here. Lots of cells that are starting to sickle. This one's starting to sickle. So this is clearly a sickle cell disease patient. See all the sickles? Beautiful. Now here's the bad news. When they show this on a step 2, they know you know the answer. So you got to take a second step here. It's all about second steps. For instance, why is the cell sickling? Well, it's sickling because of hemoglobin S. All the S's stick. When all the hemoglobin S's stick together, the cell has no choice but to sickle. Look, when you get a bunch of S's all stuck together in a row, all these hemoglobin S's, they're sticky. All these S's stick together, now the cell must become sickled shape because all the hemoglobin stuck together in a crystal. Make sense? Yeah. Now, Jose's telling me how you get hemoglobin S. That's not a normal hemoglobin. How do I get that? Well, this is a disorder where hemoglobin S is formed because you substituted valine for glutamic acid in the 6th position of the beta globin chain. The 6th position. Now, if anybody likes Star Wars, there's a good mnemonic here. In the 6th position, Lord Vader has taken over. Lord Vader has taken over the 6th position. The 6th position, Vader, yep, it replaced glutamic acid. Yep, so valine took over the 6th position. Now you're going to make hemoglobin S. Can't make hemoglobin A anymore. Hemoglobin S. Now, if only one of your genes is mutated, that means one gene is normal, you make hemoglobin A. The second gene is mutated, you'll make S. This is called heterozygous. This is called sickle cell trait. Now, if Lord Vader takes over the 6th position of both of your beta globin genes, then all you can make is hemoglobin S. That's called homozygous. That's called sickle cell disease. That's the patient that gets all the crises and terrible things we're going to talk about. So trait is relatively mild as long as you don't go to high altitude or get really acidotic. You're not going to get much sickling. But sickle cell disease, homozygous, they got big problems. So that's what I'm going to focus on. Okay? All right, now again, as I mentioned, heterozygous is this guy. They got one mutation. They got A and S. Notice 8% of African Americans are sickle cell carriers. Why so high? Why so high? What's it protective against? Malaria. Excellent, Jose. Catherine, excellent. Jolanta, Carol, Maria, Natalia, I love it. It's protective against malaria. So anywhere there's a lot of malaria, like my friends in Saudi Arabia, they tell me some areas of Saudi Arabia has a lot of malaria and they have a lot of sickle cell in those areas. Interesting. Okay, so anywhere there is or was a lot of malaria is going to have a high rate of this. Now, if one trait marries another trait, their child can get both mutations. That is homozygous, that is SS, and this is the one that has all the severe problems. So this is called sickle cell disease. Sickle cell disease. All right, now, almost all the patients with trait are asymptomatic unless they go to high altitude. I hear there's a football player, American football player, who whenever his team plays in Denver, he can't go to Denver. He can't play there because it's Mile High Stadium. He can't go to high altitude because he's got trait. I don't know his name, but there's a guy who can't go to, whenever his team plays Denver, he can't go because it's high altitude. He's got trait. Otherwise, he's a football player. He's all good. It's all good except high altitude. Now, one problem I want you to know about trait. It'll always get some sickling in the renal medulla because the renal medulla doesn't get a lot of blood. The cortex gets the blood. So the renal medulla is hypoxic and acidotic. Those are two reasons to get sickle cell crises, right? Acidosis and hypoxia. So in trait patients, they get sickling in the kidney. So they can get some blood in the urine. They can get some urinary infections. But I want you to remember they can't concentrate urine because the renal papilla gets damaged. You get papillary necrosis, and therefore they can't concentrate. What is the medical term for I can't concentrate my urine anymore? Well, urine's always the same. They call it isosose, that means equal, thenuria. Isososthenuria is a $10 word for I can't concentrate my urine. So that's what you see with traits. Not much symptoms. Maybe a little blood in the urine, maybe a little concentration problem, maybe some urinary tract infections, but that's about it. Disease is the one who gets all the bad crises. So in sickle cell disease, they get episodes of these acute, painful crises. Painful because the sickle cells are stuck in your bones and your joints. Hi, train. That's the elevated train. It gets stuck in your bone and your joints. That's going to hurt. You're going to be bent over. Your bones are ischemic. Your joints, they're going to hurt. Bones and joints. This is a painful crisis. What triggers it? Well, the classic triggers are hypoxia because hemoglobin S will stick together when there's hypoxia. Dehydration, that'll put them close together. Acidosis because it shifts the oxygen dissociation curve and makes the oxygen come off. Every time the oxygen comes off, the S's stick together. So if there's hypoxia or acidosis, they stick. Infections will do it. Infections will do it, and of course fever. These all shift the curve and therefore make the cells desaturate. Now, crisis can occur without these factors too, but these are usually the precipitating factors. So on the exam, it's going to be an African American who finishes a game of volleyball. Why volleyball? Well, because he'll be dehydrated from playing, and he'll have some lactic acidosis from all the exercise. So somebody finishes a game of volleyball, they're in pain, they're bent over, they're turning yellow. That's a sickle cell crisis. Classic. All right, now, if it's really severe, you may consider maybe they also have G6PD deficiency. Because remember, G6PD is common in African Americans. Sickle cell is also common in African Americans as well. So they get severe crisis, maybe they have G6PD with it. They can also get what's called acute splenic sequestration. The spleen could try to trap all these sickle cells, and you get a really severe hemolytic episode. In fact, eventually the spleen will get infarcted. They'll lose the spleen eventually when it keeps trying to capture all these sickle cells. Now here's a big point. When you have a sickle cell crisis, the sickle cells get destroyed, you get anemia. But what's the bone marrow going to do? When you destroy your red cells, what's the bone marrow going to do? What's it going to do? Bone marrow's normal. It's going to make more. So I want you to remember, this is a normocytic anemia with a high retic count. Excellent. High retic count. high retic count. So watch this. What if the vignette says sickle cell comes in with an anemia with low retics? Anemia with low retics? Low retics? Low. Bone marrow. Where's my retics? That's an aplastic crisis. Think about parvovirus B19. So again, a sudden drop in hematocrit with low retics, that's not a crisis. Crisis is high retics. So you see low retics, start thinking about a plastic crisis due to usually parvovirus B19, or if they have a lot of episodes, they can run out of folate. You run out of folate, you can't make red cells either. You get a low retic count. Okay, so make sure you give sickle cell patients a lot of folate. Okay, so they love this parvovirus B19. Okay, it could be myelofibrosis, but myelofibrosis doesn't usually occur suddenly. Myelofibrosis gives you anemia that's slow. So sudden onset of hematocrit that's low with a low retic. Start thinking about acute aplastic crisis. But you're right, if it was slow, it could be myelofibrosis. You're right. Excellent. Very, very good. Excellent, excellent, excellent. All right, now some important testable points. Kidney, trait, and disease. Both of them are going to get sickling in the renal medulla. You're going to get papillary necrosis. You're going to have an inability to concentrate your urine. Very testable. Number two, since it's a lot of sickling in the urine, you can get hematuria and infections, recurrent infections. All right, very important. The spleen gets destroyed. You get what's called autosplenectomy. So now you get risk of encapsulated infections like strep pneumo, Haemophilus, and Neisseria. So what should I do to all sickle cell patients? You should vaccinate, because by the time they're a teenager, their spleen is destroyed. So as soon as you diagnose sickle cell, all three vaccines, Pneumovax, Haemophilus vaccine, Neisseria. If I can only pick one, what if I'm on a desert island? I only have one needle. I can only do one vaccine. Which vaccine would be the most important? Catherine, Juan, Jolanta, excellent. You bet. Pneumovax is the most important because the number one killer is strep pneumosepsis. Number one killer of sickle cell. Because once they lose their spleen, they get strep pneumo, very common, and it gets septic and it kills them. So make sure you do the pneumovax. All right, now again, the spleen will first get big because it's trying to eat the cells, but then it gets destroyed, and that's why you get all these infections, because you get autosplenectomy. All right, now a couple problems with sickle cell. You're not going to grow good if you have anemia all the time. So growth retardation, very common. Number two, you tend to get a lot of ulcerations of your leg, the skin that doesn't heal, a lot of ulcerations. This is testable. Why do you get bilirubin stones? Because of all the breakdown. All the bilirubin, you're going to supersaturate your bile, and they're going to get stones. So very important that sickle cell could come in with pain in the right upper quadrant after a fatty meal. That's cause of gallstones. So get your ultrasound. Sickle cell's right upper quadrant pain, get the ultrasound and look for the stones. Sickle cells could get stuck in your hip. You can get infarct your femoral head. They call it avascular necrosis of the femoral head. What test should I do? Sickle cell is hip pain. Sickle cell is hip pain. What do I do? What do I do? What do I do? MRI. MRI of the hip. Look for avascular necrosis. Okay? For this one, we're going to do an ultrasound. Look at the gallbladder. Okay. Now, obviously, osteomyelitis can be an issue, but what bug is kind of unique here? What bug are they going to visit? Salmonella. Very rare, but they can get Salmonella osteomyelitis here. That's pretty darn cool. You don't see that. It's very rare, Salmonella osteomyelitis. And then a very bad thing is if it's stuck in the retina. Sickle cell stuck in the retina, you can go blind. You can infarct your retina. That's an emergency. So visual problems, that's going to be an emergency. We're going to have to do something special for that. That's an emergency. All right, now, what's the acute manifestations of a sickle cell crisis? Well, you're going to be in pain. especially the back, the ribs, the chest, because the sickle cells tend to get stuck in the bone and joints. Now, unfortunately, if it gets stuck in the chest, this is the number 2 killer of sickle cell. Number 2 killer. Number 1 was strep pneumo. Number 2 is called acute chest syndrome. Because if the sickle cells are stuck in your lungs, you can't breathe. You're basically infarcting your lungs, you can't breathe. So they're going to come in with shortness of breath, severe chest pain, fever, leukocytosis. They can't breathe, hypoxia. When you do the chest x-ray, you'll see infiltrates. So what does this sound like? Pleuritic chest pain, some fever, white counts up, hypoxia, x-ray shows infiltrates all over the place. It sounds exactly like a pneumonia. So it's indistinguishable from a pneumonia. Now, obviously, the cultures will be negative. There's no sputum. These cultures will be negative. Okay, it's going to look like a pneumonia, but it's acute chest syndrome. For this, we're going to have to do something special. This is an emergency. Okay, so for the eye and for the chest, we have to do something special. We'll talk about that in a minute. If it gets stuck in the brain, that's an emergency. You're going to stroke. Sickle cells can stroke. And if it's stuck in your male member, gentlemen, this is an emergency. If it's stuck in the male brain, I'll get an erection that doesn't go away. Question, if you have priapism for a long period of time and your penis infarcts, what must be done if your penis infarcts? But where do you cut? Cut right here. Cut right across this line. I can't live without my brain. Just don't cut there. Don't cut there. No. Cut here. What's the point of living? So this is an emergency. Emergency. So again, we got 4 emergencies here. 4 emergencies. 1 was the acute chest syndrome because that's a big killer. Number 2 is a stroke. You don't want a stroke. Number 3 is priapism. Number 4 was the retina and blindness. These are emergencies. You can also get MIs too. These are emergencies. We'll have to do something special. All right, now let's talk about presentation and then treatment. Sickle cell trait, not very exciting. Blood smears look normal. The only thing they really got is the kidney. A little isoscythinuria, maybe a little blood, maybe some urinary infections. That's about it. If they go to high altitude, that's when they can get a crisis. They go up in a plane, they go to Denver to play football, they get acidosis. That's when they can get a crisis. Otherwise, sickle cell traits are pretty decent. Just a little kidney stuff. That's about it. All right, now sickle cell disease, that's a big problem. You're going to have a mild to moderate anemia, and it'll be normocytic. But remember, retic count is sky high. If retic count is low, think about parvovirus B19 and folate deficient. Okay? Now, retic count should be about 1%. So look, it is a really high retic count. Really high retic count. All right, now in all hemolysis, LDH is up and bilirubin's up, all of them. And in urinalysis, we often see blood there. It's usually microscopic because of the sickle cells getting stuck in the medulla. You get papillary necrosis. All right, best test, most specific, hemoglobin electrophoresis to look for hemoglobin S. Hemoglobin S. Now question, what if I see this on electrophoresis? Here's S. What if I see this? You just have hemoglobin A, you're normal. Next patient, they have hemoglobin A and they have hemoglobin S. What is that? Hemoglobin A and S? That's a trait. Third patient only has S. Hemoglobin S only? That's sickle cell disease. That's homozygous. Homozygous. So electrophoresis is your gold standard. Please tell me, what was the best test for thalassemia? Thalassemia, a hemoglobin problem? Electrophoresis. So for hemoglobinopathies, the ultimate test is electrophoresis. All right, but what should I do first, Brown? What should I do first? Oh, well, the first is the blood smear. Blood smear. Remember, For normocytic, we do the retic out, and then look at a blood smear. On the blood smear, I'll see the sickle cells. Okay, so you see sickle cells. Now, if you don't see sickle cells, you can make them by doing a sickle prep, also known as the sickle dex test. Here's what we do. We take a drop of blood and we add a chemical called metabisulfate. Metabisulfate will suck the oxygen away. If it sucks the oxygen away, the cells will sickle. If you got trait or if you have disease, your cells will sickle. So I don't know which one you got, but I know you got one of them because normal blood shouldn't sickle when you make it with the oxygen away. When you take the oxygen away, blood shouldn't sickle. Okay, so this is called a sickle prep or a sickle dex test. Metabisulfate. And again, that's not something they'll ask on step 2, but they'll ask it on step 1. Metabisulfate. Metabisulfate will suck the oxygen away, and then the cells will sickle. So this is a good screening test. Good screening test. So we often start with the blood smear, or if I don't see it on the blood smear, you'll do a sickle prep to make the cells sickle. So this is my first test, but it's not specific. So the specific test is the electrophoresis, and that will confirm it. Okay, so sickle dex, sickle prep first, then hemoglobin electrophoresis. All right, now white cells. Always look at the white cells, because if you have a white count that's elevated, there may be an infection triggering the crisis. We better treat that infection. So always look at the white count. If it's elevated, maybe an infection triggering the crisis. All right, now treatment is very high yield for step 2. If you come in with an acute crisis, we gotta hydrate you because dehydration was a trigger. We gotta give you oxygen because hypoxia is a trigger. And we're gonna give you analgesics, opiate-based, morphine, opiate-based like morphine. Why? What? Because it's painful. When you're in pain, you're stressed, you're gonna make more acid. You're going to get acidosis if you're in pain. And number 2, if you're in pain, your sympathetics go up and blood vessels are constricted. Sickled cells with constricted vessels are never a good combination. So we want to get rid of the pain to stop the production of acidosis. Because you're stressed, you make acid. And number 2, to get rid of the sympathetic constriction. And also because we're good people too. We don't want to see anybody suffer, right? Okay? So this is your classic treatment. Fluids, oxygen, and analgesics, opiate-based. Now, if the white count is up even a little bit, if there's a fever even a little bit, you give antibiotics. You don't fool around here because they have no spleen. They will get septic very quickly. You must give antibiotics with any sign of infection. Any sign. Slight fever, slight white count. You're going to use something that covers encapsulated. So we're going to use ceftriaxone. That's typical we use. Now you can use these other drugs too. It doesn't matter. But ceftriaxone is usually the standard. We start with ceftriaxone, but any of these drugs that cover the encapsulated organisms would be perfect. Okay? We always do peripheral blood smear first, then the sickle dex will be done second. Peripheral blood smear first, sickle dex second. Okay, because everybody gets a CBC and a blood smear. Everybody. In hematology, that is your first test always. It's very easy. CBC and blood smear. CBC and blood smear. So it is always. Now, if the blood smear shows sickle cells, you don't need a sickle dex. If the blood smear doesn't show sickle cells, but you still think it's sickle, you get a sickle prep. Okay, good. I like it. See what you're doing? That's gunner level. Don't memorize what I'm saying. Think it through. Understand what should I do first? What should I do second? What should I do third? Not only will you rock step 2 and 3, but you'll be an all-star on the wards. I'm proud of you. Proud of you. Excellent, excellent, excellent. All right. So far, so good. Go forward. Oh man, my slide is like, yeah. But if you're thinking sickle and C, would you not do electrophoresis first, then sickle? Well, again, sickle prep is very easy to do. It's very easy. Very easy to do. I do it right there in the office. Sickle prep is easy to do. Electrophoresis takes a long time to do. Okay, so you usually can do the prep while you're waiting for electrophoresis, right? So we do the easy things first. Sickle prep is easy to do. Electrophoresis costs money, takes time. So that's usually how we confirm things, electrophoresis. Okay, good. I like it. I like it. I like it. All right, now what do we do for emergencies? Either the acute chest syndrome, priapism, eyes, brain, heart. You do an exchange transfusion. This is for the severe or life-threatening manifestations. Life-threatening, like acute chest syndrome, strokes. Life-threatening, like losing a vital important part, heart, retina, losing vision. So if you're going to lose something, we want to do an exchange transfusion. Now, what the heck is that? Well, I hook you up to a pheresis machine. I take out your blood, spin it in a machine, throw out your red cells, throw them in the trash, and then transfuse in normal blood that won't sickle. We're going to do 5 units. We're going to exchange 5 units of your blood. Holy heck. Yep. Have you got an oil change on your car? This is an oil change of your blood. Your blood is sickling somebody else's. Now please don't bleed them 5 units out. And then you put 5 units back in. No, we do it at the same time with a pheresis machine. Pheresis takes it out and puts it back in at the same time. Okay? Don't take out 5 units and then put 5 in. They'll be dead. Pheresis machine will spin it, take it out, and put the new stuff in at the same time. Okay, same time. Yeah, I just didn't say, wait, take 5 units out? Yeah, with a machine does it at the same time. It's pretty radical, isn't that? You're exchanging the blood. We only do this for the emergencies. And again, step 2 is about management, initial management. So this is a very high yield point. It will be tested. So again, only for emergencies, not for a crisis, for an emergency, critical organs. All right, now for chronic management of these patients, number 1, they're going to need folate. Because of all the turnover, they're going to run out of folate. Make sure you give them folate. They're going to need vaccination. Give them vaccination. And number 3, genetic counseling. Genetic counseling. Who they marry is important. They can pass this on. It's genetic, right? Okay. Yeah, what we do is we hook you up to a pheresis machine. So here's the patient. Here's the patient. We take the blood out of this arm, goes into the machine. The machine will spin the blood and separate the white cells, the plasma, the red cells. It will throw the red cells in the trash because their red cells are sickling. Then in the same machine, we've got a unit of normal blood that's going into the machine. The unit of normal blood will take the place of the red cells you threw out. And then we'll put the mixture back in the arm. Got it? That's how you do it. Okay, so I'm going to give you 5 units of healthy blood and take out 5 units of your sickling blood with the pheresis machine. Okay, good. Yeah, you don't save their blood. Their blood's no good. Take their blood and throw their blood out. Okay, the sickling blood goes out. The fresh packed units go in. It's all good. And you do it over time. It takes a few hours to do, but you got to get it done. It's an emergency. Now, very important, to decrease the crises, a couple things you can do. Number 1, hydroxyurea, very important, because this is going to increase the fetal hemoglobin. That's going to dilute the sickling one. So this is asked quite a bit. If I give you hydroxyurea, increases fetal hemoglobin, so therefore your S's are less likely to stick because there's a fetal hemoglobin in the way. It's in the way. So it'll decrease the frequency of crises. Now we usually do this when you're having 4 or more crises a year. So if you're having 4 or more crises a year, we typically use hydroxyurea because 4 times in the hospital a year is a lot. It's too much. So when you're having 4 or more crises, we will give you hydroxyurea. Again, do not give it during a crisis. It doesn't work in a crisis. You give it between the crises to decrease the chance of a crisis. Okay? Okay? How often do they need a transfusion? That's only for emergencies. You only do a red cell exchange transfusion rarely if they have priapism. It's a rare complication. If they get it, we'll have to do it. It's only for emergencies. So hopefully those are rare. Hopefully those are rare. And again, if they're having a lot of episodes, we'll give hydroxyurea to decrease the likelihood they'll get these painful crises and need these emergent procedures. Good. Now, the only known cure is a bone marrow. It's your only known cure. Okay? You can cure about 80% or more of children. So if these children have really bad sickle cell cases, transplantation is a good idea if you can get an HLA matched donor. So we transplant them. Now adults don't do so good. So if you're going to do a bone marrow transplant, you do when you're young. You do when you're young, and you got a good chance of cure. Okay, because sickle cell disease is a very devastating disease. You're going to see it on the wards. These patients suffer painful crises 3 or 4 times a year. Oh, terrible. All right, so bone marrow transplant is something to consider. And it's, by the way, it's the gold standard for children. For adults, they don't do so well. Adults don't do so well, so do it as a child. All right, now another type of anemia is an acquired hemolytic anemia. It could be autoimmune, your body's attacking your red cells. It could be an IgM, a cold agglutinin disease. It could be due to a drug sticking to your red cell. Do you remember the Hampton reaction? When a drug sticks to the red cell, now you make an antibody against it, and you get a hemolytic anemia. Okay? All right, so you can have autoimmune, you can have cold agglutinin, you can have drug-induced, you can have a bunch of reasons that you can get hemolytic anemia. All right, now, as I mentioned, for autoimmune types, it could be a warm antibody, it's an IgG, or it could be a cold agglutinin, IgM. IgM works in the cold. I wasn't working around. Cold. IgM cold. Grrr, hot. Grrr. IgG is a warm antibody, works at body temperature. IgM works at cold temperatures better. Okay? Now, also, it could be complement. Complement C3. C3b. Now, that usually gets cleared in the liver, by the way. C3 usually gets cleared in the liver. IgGs usually get cleared by the spleen. All right, now, when you have acquired hemolysis, it's usually a sudden and idiopathic. We don't know why you get autoimmune. Sudden idiopathic. Now, it tends to be mostly extravascular. It's usually liver and spleen. Liver and spleen. That's where things get destroyed when they're coated with antibodies and C3. All right, and again, it's macrophages in the spleen or the Kupffer cells of the liver. Now, liver, again, is more C3. IgGs are usually in the spleen. All right, now let's talk about autoimmune. Autoimmune. They like this autoimmune hemolytic anemias. Now, it's idiopathic. Why do you get autoimmune diseases? Nobody knows. But we know this. They're most common in women in their reproductive age. That's who gets autoimmune, women in the reproductive age. But it can also be triggered by things. Leukemias, especially CLL. This is a lymphocytic leukemia. It can make antibodies against you. Same thing for lymphomas. If it's a B-cell lymphoma, it can make antibodies against your red cells. Sometimes viral infections. You attack the virus, you wind up attacking your own red cell. Lupus. Lupus makes antibodies against everything. Don't be surprised if lupus comes in with anemia. And we talked about the Hampton reactions like penicillin. Penicillin sticks to the red cells. And of course, there's a bunch of other drugs here too. Cephalosporin, methyl-dopa is a big one. Methyl-dopa, procainamide. These can all cause a hemolytic anemia. All right, now as I keep mentioning, all hemolysis tends to be very acute and sudden. Sudden. So if it's very sudden, you could get a fever. You could get such anemia that you get fainting. You get congestive heart failure. And of course, you can get hemoglobin in the urine if it's more intravascular. If it's extravascular, you get splenomegaly, but it takes time. It takes time. So it has to be a chronic one. To get splenomegaly, it's not one episode. It's got to be a chronic autoimmune disease. Then you'll get a big spleen over time. And of course, if it's due to drugs, look for the history of taking a drug. I took a drug, then I got anemia. Maybe the drug is responsible. All right, now what's it going to look like when it's autoimmune? Well, again, hemolytic anemias tend to be normocytic, and they tend to have a high retic count because the bone marrow will make more. If you destroy these, you'll make more. Now, LDH is up for all hemolytic anemias. Haptoglobin, if it's intravascular, is usually decreased, and you're going to see a lot of bilirubin. You'll turn yellow every time there's hemolysis. Now, very important, Coombs test, autoimmune Coombs test. Coombs test is looking for antibodies. The direct Coombs test looks directly on the surface. You can look for IgGs. You can look for IgMs, cold agglutinins. You can look for complement, C3b. So for autoimmune disease, this is your test. Autoimmune anemias, Coombs, 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 direct Coombs, direct Coombs, direct Coombs. No matter whether it's cold, warm, if it's to the complement, direct Coombs will pick it up. Okay, so direct Coombs is the key for hemolytic acquired diseases, autoimmune. All right, now another clue here will be spherocytes. See the spherocytes? You see them? You see them? Do you really see them or not? Students say, oh yeah, I see them. But where are they? Do you see them? Okay, take a look. This red cell has no central pallor. No central pallor, that's a spherocyte. It's supposed to have a clear space in the middle. No central pallor. How about this one? No central pallor. How about this one? No central pallor. 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 Do you see them? There's no central pallor. That's a spherocyte. Now they like them because students don't always see them. They don't see them sometimes. They miss them. So I want you to see that. Look at that. So I'm going to circle them for you. No central pallor. Look, it's supposed to be that's normal. Central pallor, right? No central pallor. That's a spherocyte. Okay? Now, direct Coombs is confirmatory. Look for direct Coombs. Now, what are you going to do for an autoimmune disease? Well, if it's really mild, the episode will go away. If it's due to a drug, stop the drug. And then finally, if it's autoimmune and it's pretty bad, what do you do for all autoimmune diseases? Steroids. Steroids. Autoimmune steroids. Now, if it's really bad and chronic, you may have to take out the spleen. You may have to take out the spleen. And if they're unresponsive, the steroids don't work, you have to take the spleen because the spleen is where the destruction is. So always steroids first. Steroids fail, splenectomy. Steroids first though, autoimmune steroid. Get through the acute episode. Autoimmune disease come and go, come and go, come and go. Get them through the episode. Maybe it'll go away and stay away for a while. Okay? If it continues after splenectomy, well, there's autoimmune, there's drugs we can use like rituximab. Rituximab would be a classic one. Rituximab. Yeah. Rituximab would be next. You bet, Tyler. Rituximab or other immunosuppressive like cyclophosphamide could be used as well. Some immunosuppressive. Okay? Indirect Coombs is used for antibodies in the blood. So if you wanted to blood type somebody, if you want to do like, does he have anti-A, does he have anti-B? That's when you look in the blood. Indirect is for the blood. Stuff stuck on the surface, direct. Direct Coombs, direct Coombs, direct Coombs. Look directly on the surface. Okay? All right, now what about cold agglutinin disease? Well, cold agglutinin is an IgM. It's an IgM. So you're making an IgM against your red cells. When does this happen? Well, it happens with malignancies like lymphoma and Waldenstrom's macroglobulinemia. Macro, because it's a pentamer. IgM is a pentamer. It's a macroglobulin. So IgM occurs with malignancies like Waldenstrom's. It occurs with infections like mycoplasma and mononucleosis. I'm seeing a lot of M's here. I'm seeing a lot of M's. So IgM, malignancy like Waldenstrom's macroglobulinemia, infections like mycoplasma and mono, and sometimes you can see it with inflammatory bowel disease. Now, 50%, we don't know why you got it. You just got an IgM. You don't know. You just got it. All right, now, here's what's cool. IgM is a pentamer. So when it gets in the cold areas of your body, cold areas like your fingertips, your nose, your toes, your ears, when the blood gets to the cold areas, the IgM will stick. Now, IgM is a pentamer. What does that mean? It means there's 5 antibodies stuck together. 5 antibodies stuck together. It's 5 antibodies stuck together. 1, 2, 3, 4, 5. 5 antibodies stuck together. So therefore, a red cell gets stuck to that one, a red cell gets stuck to that one, a red cell gets stuck to that one. This is called agglutination. IgM is going to agglutinate. All the blood are stuck to it. One's here, one's here, one's here. That's why it's going to agglutinate. And again, it only sticks to the red cell in the cold. The IgM doesn't stick in the warm. When what's here, doesn't work. When it gets in your fingers and toes, it sticks them all together. That's why they called it cold agglutinin. It only sticks the blood together in your fingers and toes. So when it sticks it together, your blood sludges and your fingers turn blue. That's why they get the cyanosis, because it sticks together in your fingers and toes and they turn blue. They turn blue. Now, question. IgM is going to fix complement. So now C3b is going to be on the surface here, because IgM's great at fixing complement. So C3b is on the surface of these cells now. All right. Now, what happens when this blood gets back to the warm area? Gets back to the warm area, what happens to the IgM? It comes off. The IgM comes off. It doesn't stick anymore. It only stuck where it was cold. Now it gets back here. It comes off. So now the red cell is free, but it still has C3b on the surface. So when this gets to the liver, the Kupffer cells will now eat it. That's why you get the anemia. So let me repeat. What is cold agglutinin disease? It's somebody who makes an IgM. So when their fingers get cold, the blood agglutinates and the fingers turns blue, the nose, whatever turns cold gets blue. And then you get anemia because when it gets back, the IgM comes off, but there's still complement here. So it gets destroyed by the liver. Make sense? So question, is splenectomy going to help this? Is splenectomy going to help this? Oh, see, that's the most common wrong answer. Remember, IgG, 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 spleen eats it, splenectomy, steroid splenectomy, ain't gonna work here. Ain't gonna work here. Make sense? And steroids not gonna affect C3b either. Steroids gonna have no effect on that. So steroids and splenectomy don't work here. They don't work. Now again, since you're having hemolysis in your liver, you're going to get anemia. So you're going to be pale, you're going to be jaundiced, you could have some dark urine because there will be a little intravascular complement lysis here too. So you get a little bit of dark urine as well. So a little intravascular. All right, now the treatment here is to avoid the cold. Don't get cold when you have an IgM. Don't get cold. Now again, I can't use steroids. Can't use splenectomy. So what can I do to stop the IgM? I can give rituximab because it hits B cells. It'll stop the B cells from making IgM. So again, we avoid the cold. If that is not enough, insufficient, we'll add rituximab. Now, if it's really bad and the rituximab is unsuccessful, then we got to do big gun immunosuppression to stop the antibodies. Big gun immunosuppression. But that's only done if the avoiding the cold has failed and the rituximab's failed. Then we're going to add this. And again, the most common wrong answer will be steroids and splenectomy. They don't work. It's the liver and it's complement. It's not the antibody, it's the complement. Got it? So that's a very nice question. It's pretty uncommonly asked, but when they ask it, students miss it. Okay? All right, now You have to compare hereditary, because it had spherocytes. You got to compare hereditary spherocytes to autoimmune. Autoimmune, the IgG one, had spherocytes. So let me go back here. Let me just make sure we got this. This was IgM, cold agglutinin. If I go back here, this spherocyte, these are going to be coated with IgG. IgG on the surface here. And these are going to be destroyed in the spleen. So they're going to get splenomegaly. Okay, so when I have autoimmune hemolytic anemias, you're making IgG against the red cells. So you have a big spleen, and you're going to have spherocytes. Big spleen, spherocytes. So I have to tell this autoimmune hemolytic one from hereditary spherocytosis. They look similar, okay? Once steroids have been done, they don't really work. They don't work with the IgM. They work with the IgG. IgG, the steroids work. The IgM, it doesn't seem to work. Okay? All right, so differential. I see spherocytes. Is it hereditary or autoimmune? Hereditary or autoimmune. That's my job on a step 2. So before I do that differential, we should take another break, right? Because I don't want to overwhelm you guys. I know there's a lot of material here. So let's take a break, and we'll come back and we'll do our final hour. Okay, and I'll do a little review at the end to make sure we didn't miss anything. Okay, hang in there. I know nobody likes blood. All right, take a well-deserved break. See you guys in 10 minutes.